All right. Sue, the floor is yours.
Welcome. Thank you for joining us today. I'm Sue Birch, Director of the Healthcare Authority and Chair of the Universal Healthcare Work Group. Before we begin, I'd like to take a moment to reflect on and acknowledge the significant and historic events happening across the country. In addition to COVID-19, which has devastated our economy and overwhelmed our healthcare system, we continue to see deep social and racial injustices. Too often, the quality and accessibility of healthcare is determined by someone's zip code, skin color, and income. That is wrong and is the result of many years of systemic racism and oppression. We can and must do better for those we serve. We are reviewing our strategic approach to health equity. We strive to find meaningful and strategic ways to use our purchasing power to influence health outcomes, including making healthcare accessible and affordable to all who live here in Washington. All of our work should be done through the lens of equity. This includes examining our hiring practices, our contracting practices, how we engage in outreach with communities on equity issues, and how we train our employees to understand and consider issues of health equity in their work. We at HCA know that Black Lives Matter movement is important, and we remain committed to working with communities that have been marginalized and oppressed. We stand with the families and communities of George Floyd, Ahmaud Arbery, Breonna Taylor, Eric Garner, Trayvon Martin, and countless others. And we stand with them to end systemic racism. Now, for today's presentation, we are going to be focusing on a COVID-19 briefing for the Universal Healthcare Work Group members. As you know, we have seen significant changes and impacts to our healthcare system in response to the COVID-19 pandemic. Providers, payers, communities, and the families of Washington have experienced major disruptions that quite literally changed overnight. Although we are slowly emerging from the pandemic, these impacts will be felt for many, many months, and in some cases may result in lasting change. The goal of this presentation is to update you on some of the impacts of COVID-19 to Washington State with respect to healthcare coverage, share important work that is being advanced by the state, prompt a discussion for the Universal Healthcare Work Group on potential impacts of the pandemic. Let's move on to the next slide. We're going to start our presentation with an overview of process updates from the Health Management Associates, or HMA team. They are managing the Universal Healthcare Work Group in conjunction with HCA. We will provide an update on the immediate impacts to Washington State budgets and the healthcare market. We'll also provide a few highlights on HCA's response activities, highlighting some of the important work we're doing to support Washingtonians and stabilize the healthcare system. And now I'd like to hand it over to Liz Arjun with HMA to provide updates on work group processes in response to the pandemic.
Thank you, Sue. And thanks to HCA and the other state agencies who've created today's presentation and are spending the time to make sure that you all are aware of the latest information about what's happening as a result of these things happening in our community. We know that what is happening is having a significant impact on the landscape in which we are doing our work together, and it's important to have the most current information as we move forward in our charge this year. Everybody's focus has been on the COVID-19 response, and however, I just want to update all of you on what the project team, including HMA and HCA, are doing to make sure we meet the expectations of the work group and the requirements of the legislative proviso. Due to social distancing guidelines, work group meetings are moving to Zoom. We will continue to meet this way until further notice. We're working to make sure our meetings are focused on dialogue and the time for deliberating together, and we will try to minimize presentations during the virtual meetings by doing pre-recordings such as this to make that happen. In addition to this special COVID briefing, there's another presentation with background information in advance of the work we'll be doing on June 24th. I ask that you please do your homework by reviewing these presentations because it will make our time together more fruitful. So thank you, and I'm going to hand it back over to Sue.
Thanks, Liz. We're going to now hear from a few others for updates on the impacts of COVID-19. We'll lead off with Thea Mounts and Jason Brown from the Office of Financial Management, and we refer to them as OFM.
Thanks, Sue. I'm Thea Mounts, Senior Forecast and Research Manager at the Office of Financial Management. Over the next few slides, I'll provide information about the unemployment situation in Washington, as well as the uninsured population. Then Jason Brown will provide an update on state budgetary challenges. As you all know, thousands of people in Washington have lost their jobs over the last several months due to the COVID-19 pandemic. In April, the unemployment rate rose to 15.4% from 3.8% in February of this year. This is the highest jobless rate since the Great Depression and represented over 610,000 unemployed individuals. All major industry sectors have posted significant job losses except for the information sector during this time, and the number of people receiving unemployment benefits reached a record level, topping 575,000. Next slide. The uninsured numbers in the next several slides are all based on the 2018 American Community Survey one-year public use microdata sample files, or ACS PUMS data. To provide 2019 and 2020 estimates, additional data from the Office of Financial Management's population projections, the Employment Security Department's weekly unemployment insurance claims, Medicaid enrollment, and the Health Benefit Exchange enrollment data are used in the model. Next slide, please. We start first with the 2018 uninsured population. In 2018, Washington had an estimated 467,000 uninsured individuals. This group can be divided into three immigration status categories: citizens, lawfully present, and the undocumented immigrants. In this chart, you see those three categories plus the total broken out by the federal poverty level, their income level. 21% of uninsured citizens had incomes between 0 and 138% of the federal poverty level, whereas for lawfully present and undocumented immigrants, roughly 1/3 were in this income category. The pattern continues across the 139 to 400% federal poverty level. The lawfully present and undocumented immigrants have larger percentages in these lower income categories. Citizens have a larger percentage of uninsured in the highest income category. Next slide, please. This table contains the same information as the previous slide, although with more detailed federal poverty level breakouts. I won't go through the detail, but you have this for reference with the detailed categories from 0 to 138% up through 501% plus category by the three citizen or immigration status categories. Next slide, please. Next, we'll look at the estimated impact of the pandemic on the uninsured population. In 2008, the overall uninsured rate in Washington was 6.2%, and the uninsured rate for adults 18 to 64 was 8.9%. Both rates increased slightly through 2019, and by January 2020, the rates were estimated to be 6.7% and 9.7% respectively for the two categories. Taking into account the unemployment claims filed, as well as the Medicaid and Exchange actual enrollments, by mid-May, we estimate that the uninsured rates were 13% overall and 19.4% for adults 18 to 64. Next slide, please. We estimate that among those who have become unemployed, 63.6% had employment-based insurance before the COVID-19 pandemic began, but that only 13% had unemployment-based insurance as of mid-May. Furthermore, the percentage who were uninsured from that category jumped from 9% pre-pandemic to nearly 58% during the time period. Not surprisingly, estimates for after the pandemic began also show incomes across the three immigration status groups slipping. Now I'll turn it over to Jason for the next slide.
Thank you, Thea. Due to the COVID emergency that is currently happening within our state and our nation, the budgetary challenges have increased. The recent revenue forecast for the state has taken a hit and is roughly $7 billion lower than the previous revenue forecast that the state had for the next 3 years. This is due mainly to decreased retail activity and consumer spending. With these reduced revenues, OFM has asked the state and its agencies to freeze hiring and personal service contracts. This will help protect state funds for the most essential services within the state. The state has also been asked to provide 15% reduction options to the governor so that we could make better use of our state funds and protect our budget. And thank you for that. Next slide.
Thanks, Thea and Jason, for that. As my colleagues from the Office of Financial Management just shared, we experienced a tidal wave of Washingtonians applying for unemployment benefits over the last few months. As research has shown, this often is the first step on the journey to critical services for individuals in times of natural disaster, crises, and now in pandemic. Typically, after someone experiences sudden loss in employment, their existing healthcare coverage will run for another 30 days post-employment. Therefore, we anticipated, and our trend has shown, a slightly delayed wave of applications for Medicaid as opposed to what you saw for those applying for unemployment. On this slide, you'll see that since April 1st, we have seen over 50,000 new enrollees join the Apple Health or Medicaid coverage within Washington State. For purposes of how we're defining new enrollees, we're looking at those that have not previously been on any type of Apple Health or Medicaid coverage anywhere in the last 6 months. So this equates to roughly 1,200 to 1,300 new enrollees each day, Monday through Friday, on average, that we're seeing applying for our coverage. When we look at this a little bit further, we can see that about 66% of the total new enrollees that we've seen from April 1st through June 1st were predominantly spread across 5 counties. And this isn't all that unknown to us. This same spread or percentage difference is what essentially we see with how our Medicaid distribution looks today. So now, expanding the lens on healthcare coverage in Washington, I'll turn to my colleague, Joan Altman from the Health Benefit Exchange.
Thanks so much, Taylor. Hi, everyone. My name is Joan Altman. I'm the Director of Government Affairs and Strategic Partnerships at the Washington Health Benefit Exchange. We run Washington Health Plan Finder, which is the portal that 1 in 4 Washingtonians are using to access health coverage either through Apple Health or through qualified health plan products. Pleased to be here joining Healthcare Authority and our other state agency partners to talk about COVID and our COVID response. I'll be talking in particular about an uninsured special enrollment period that we opened in response to the pandemic. I'll be stepping through some of the detailed data we've seen both from our system and from consumer surveys that we put in the field discussing affordability with our consumers. And finally, I'll talk a little bit about Cascade Care implementation, in particular, a legislatively mandated subsidy study that we will be working on this summer and presenting this fall. Next slide, please. First, I wanted to provide a quick overview of some of the work we've been doing in partnership with OIC, Healthcare Authority, OFM, and others. In addition to the special enrollment period that I'll be discussing further, we've been engaged in statewide outreach through our Navigator Broker Assister network. We have several thousand people across the state who, in spite of COVID, shifted to virtual work and have been continuing to help us with our statewide outreach and one-on-one assistance. We've also been working closely with federal partners and agency partners to leverage some of the flexibility we have as a state-based marketplace. As opposed to some other states that are based on the federal platform, we are based on our own state platform, and as a result have been able to exercise some flexibility related to keeping our customers enrolled and during this time. And that has involved working with Healthcare Authority to sort of grant extensions to qualified enrollees, and also working with OIC on issues like grace periods, and finally working internally on some of our own policies and procedures related to verifications to try to maximize the number of people that we have kept enrolled during the pandemic. Finally, we also have quite a large Spokane Valley-based customer support staff that we were able to transition to be able to continue supporting customers during the pandemic, in addition to our own staff at the exchange. Next slide, please. Here is a quick look at our statewide enrollment assistance network. We have lead organizations that you see listed on the slide that cover service areas across the state. And as I mentioned, this has significantly changed how we do our outreach, but not the one-on-one assistance that we have available. And we're currently evaluating best practices now to inform our next open enrollment period. I can't believe it's our 8th open enrollment period that will be starting November 1. Next slide. This shows you a bit about where we're focusing today. We're obviously focusing on customers who are losing their jobs, as you heard from Thea. We are seeing an unprecedented number of people apply for unemployment benefits, and really wanting to make sure for those who are losing their employer-based coverage, that linkage is tight to make sure that if they know about the exchange. Many of these people have had employer-based coverage for their entire careers. So this is a new learning process for them. And in some ways, we're sort of launching all over again with a new audience in the state. We're also focused on consumers who are furloughed right now. We've been working closely with employers and know that there are some people who are maintaining their employer-based coverage, but it may not last very long. And finally, we're working with customers who are either heading into or coming off of COBRA. The exchange provides an affordable option relative to COBRA, and we want to make sure people are aware of those options and also aware that they get a special enrollment period when they're coming onto or going off of that coverage. We've also been working quite hard to accommodate federal changes. There have been several different stimulus bills that have had a downstream impact on our system and our customers. That includes new rules about reporting unemployment income that we've been implementing. We're obviously closely watching our market movement and talking more about that. At a high level, we are seeing increased utilization of our special enrollment periods related to loss of coverage and loss of income. And we're also seeing increased churn from qualified health plan coverage to Apple Health. It's about twice as much as we've seen last year at this time. We're also just continuing to explore different affordability options, including looking at carriers providing some premium relief, and that's an ongoing discussion with both them and OIC. Next slide, please. Here are just some resources for those of you who are interested in learning more. We've been developing some sector-specific materials in partnership with Port of Seattle, Boeing, Alcoa, the Labor Center, and others, and have made many of those available online through our partnered toolkit. We also have worked to maintain our sort of COVID FAQ page, which speaks directly about some of the scenarios I just mentioned: job loss, furlough, etc. Next slide. Here's a brief look at our COVID campaign that we did driving toward our special enrollment. Sort of move through this quickly and get to some of the data and some of the outcomes we saw from that campaign. Next slide, please. So here are some top lines from the uninsured special enrollment period. It ran from March 10th to May 8th. We were the first exchange to open a special enrollment period for this purpose, and there's been a lot of interest in this data. So a lot of detail is available to you online. I'll just be speaking to the top lines today. We had 22,000 customers come in and sign up for coverage. About 7,000 of them were customers who used the new uninsured SEP. About 15,000 people who signed up during that time came in through those existing special enrollment periods I mentioned, like job loss or change in income. And you can see on the lower right-hand side of the screen that we had about double the activity this year compared to 2019, driven mostly by both the uninsured SEP and also people losing their coverage. So we are seeing people come over who've lost their employment-sponsored coverage. It's not as high as we would have expected, and we're continuing to look into that along with caseload forecast experts and others. Next slide. Here are sort of what has emerged from the data so far. First, we saw a much higher percentage of new customers come in. Typically, in open enrollment, we see about 20% of our customers, 20, 30, 40% even are new. Compared to this most recent open enrollment period, which was 19, we saw 75% of the customers who came in were new customers. And we defined this even more expansively than HCA to mean anyone who wasn't with us in 2019 or 2020, who's coming in for the first time in years to see us. And that's quite an overwhelming percentage. We also saw a higher percentage of people of color use the new uninsured SEP, which we were pleased about. Obviously, when you look at unenrollment statistics, there's a health disparity there. And so this was driven mostly by Asian customers, where there were about double compared to what we saw in open enrollment 7. And finally, we saw a higher percentage of younger customers. So that 18 to 34 set, who's typically elusive, usually it's a quarter of our enrollment or less, we saw it move up toward a third of the people who were enrolling in both the uninsured SEP and the typical SEP. Next slide, please. That being said, we have still been seeing some gaps. We've discussed the difference between the unemployment and the signups through the exchange. We're also closely watching those who sign up for coverage and those who pay. So you can see in the graphs here for both the uninsured special enrollment period and our sort of typical ongoing existing special enrollment periods. We always see a 10 to 20% gap between the people who sign up and the people who are able to pay. We see that gap increasing as you look to the right as we've continued on since the special enrollment period. That difference has grown, and we know from what customers tell us when we survey them that part of that is due to affordability. Next slide, please. Affordability remains a barrier at the exchange. It's one that we've been working in partnership to try to address over several years now. We have qualified health plan consumers who spend up to 30% of their total income on premiums. COVID has obviously exacerbated some of these affordability challenges for our customers, and we have a sort of renewed sense of urgency to try to address them. A majority of our enrollees are in high deductible plans, and we have out-of-pocket maximums that are quite high. In speaking to our customers, we know 40 to 60% of those surveyed indicated they'd skipped a medical service due to costs, and top of mind in a pandemic, it's worth noting that the top 2 services skipped were going to the doctor and getting a medical test. Next slide, please. Part of the work we're doing to address this is to implement Cascade Care, which the legislature passed, and sort of a 3-pronged approach to address affordability. Qualified health plans or standard qualified health plans are being implemented on November 1st to address deductibles, to bring down the cost of deductibles and address cost sharing. Public option with healthcare, which Healthcare Authority is driving. Those plan offerings will also be offered November 1st as an attempt to bring down premiums and costs for consumers and increase quality. And finally, the third piece, the subsidy study, is we are working on, in conjunction with Healthcare Authority and OIC, which will be to put together a plan to implement and fund a state premium subsidy through the exchange for people up to 500% of the federal poverty level. Next slide, please. This slide shows you a brief overview of the subsidy study requirements. And it's something, again, that we'll continue to drive toward this summer. Notably, in the legislation, there's an affordability goal that would limit the participant premium spend to no more than 10% of income. Next slide. That concludes my remarks. There's additional information in the appendix for those who are interested. Also, a lot of detail available online, as I noted in the presentation. And with that, I'll pass it over to Jane.
Thanks, Joan. Good morning, everybody. My name is Jane Beyer, and I am Commissioner Kreidler's Senior Health Policy Advisor. So I really appreciate the opportunity to talk here today about what we see happening in the commercial health insurance market and what work the Commissioner has done during the COVID-19 pandemic. Next slide, please. So this graph shows you what has happened to large group, small group, and individual market enrollment between January and April of this year. Unfortunately, we don't have the May enrollment data yet. We'll be adding that probably within the next couple of weeks. But the first thing I want to say is when you see the decline in enrollment, especially in the large group market, how thankful we are both for Apple Health Medicaid program and to the exchange for essentially the safety net that those two programs provide to folks who would almost undoubtedly otherwise be uninsured. And I would note that when we talk about commercial health plans, the information that I'm giving you does not include self-funded employer health plans. And those are health plans in which the employer bears the cost of coverage for their employees rather than contracting with a health insurer to do that. We estimate that there are about 2 million folks in Washington state who are covered by self-funded employer-sponsored health insurance. And when you look at this table, the thing that's very interesting about it is when we drill down into what was happening with the loss of coverage, we saw big drops in self-only coverage. But we did see that about half of what would have otherwise been losses of coverage were actually addressed by dependents up to age 26 and spouses who were able to enroll in their spouse's health plan as a dependent. So at least fortunately for those families where you had two folks in a family who were eligible for employer-sponsored coverage, it appears that the ability to jump on to dependent coverage has helped to soften what the damage otherwise has been and could have been with respect to the loss of health insurance coverage during the pandemic. And I would note that for the individual health insurance market, both small group and individual health insurance premiums and health plans proposed premiums have to be filed with the Office of the Insurance Commissioner on May 21st. And we were able to announce last week that on average, the insurers, in addition to having more plans and more insurers in the individual market, there's a proposed average rate decrease of about 1.8%. And I would note that that's proposed. Our actuaries right now are working hard to really carefully analyze those filings. And we'll have information about the final premium changes in August or September. So if we could go to the next slide and the next. Fortunately, back in 2009, the legislature gave the insurance commissioner authority to take emergency actions when the governor declares an emergency, as Governor Inslee did on February 29th. And most importantly, for our purposes, those emergency orders and that emergency authority encompasses the commissioner taking action to try to sustain medical coverage and ensure access to care. And the initial duration of an order is 60 days with 30-day extensions possible. Next slide. And so this slide sort of is in a nutshell, and I'll go into a bit more detail in the next slides with respect to what the commissioner has done. He has issued 4 emergency orders specifically related to health insurance, has issued 2 sets of frequently asked questions which sort of elaborate on the orders and how we're interpreting the orders. We've worked really closely with insurers who have small and large employers who wanted to do things like reduce the number of hours that would be required to qualify for health insurance, or eliminate waiting periods if somebody's furloughed and then comes back onto the job, or rather than treating somebody as fired, treating them as on an unpaid leave of absence. Basically, whatever we could do, we worked with the insurers, and when they would file those requests to change their coverage eligibility rules, we expedited those to try to get them taken care of. And then in addition, we had a couple of requests from carriers for premium forgiveness for group health plans, small group and large group health plans. One was a one-time premium forgiveness of 10% for United Healthcare and another 15% for Premera. One time meaning 1 month's worth of premiums. And that, we think, was at least in part due to the fact that when Governor Inslee ordered basically a delay of non-emergent healthcare services, the health insurers saw reductions in the claims that they were getting because of this sort of slowdown in non-urgent care. And throughout all of this, we want to give major kudos to Healthcare Authority, Department of Health, HVE, and the Governor's Office, and OFM. We have been trying as much as possible to be consistent with each other in terms of the policies that we're adopting, and to really use each other's expertise where we are lacking. For example, OIC doesn't have clinical expertise, so we've relied heavily upon HCA and the Department of Health for that. Next slide. Probably the most significant area where the commissioner has taken action relates to telemedicine or telehealth. The commissioner issued an emergency order that broadened the methods that could be used to provide telemedicine, probably most notably and especially important for folks who live in rural areas and for behavioral health providers. We authorize telephone as a means to provide telehealth. We also reached out to the governor's office. We know that for very many providers, being able to be paid the same for a telemedicine visit as they would for an in-person visit during this pandemic has been absolutely critical, especially for pediatricians and primary care providers and behavioral health providers. And we determined that the Office of the Insurance Commissioner didn't have the statutory authority to order telemedicine payment parity. We did reach out to the governor's office. They were remarkably responsive. And within a day of the commissioner issuing his order on telemedicine modalities, the governor issued his order requiring telemedicine payment parity. And as we know, as with all of the governor's orders, the ability for those orders to continue are contingent upon legislative approval by legislative leadership. And the most recent extension of that order goes to June 17th. The commissioner has been very, very supportive of the legislature extending the telemedicine payment parity order and also extending our own order related to telehealth modalities. Next slide, please. With respect to prescription drugs, very early on March 5th, the commissioner issued an order. We were very concerned about people being able to get a refill of their medication so that they would have an adequate supply of meds during the pandemic. And so we required carriers to allow early refills of a one-time refill in order for consumers to be able to maintain an adequate supply of their medication. And then there also were supply issues with chloroquine and other drugs in that class. And because of the folks who have rheumatoid arthritis or lupus who depend upon that drug, we did allow the carriers to place quantity prescribing limitations if they had concerns regarding the supply of the medication. Next slide, please. And other health issues that we addressed in the order, and these orders are still in effect. We basically said there could be no cost sharing and coverage had to be pre-deductible for COVID-19 testing for respiratory panels. For example, if a physician said, well, before I test you for COVID-19, we should test you for flu to make sure that we can rule that out. And then the associated provider visit. Many of you have heard discussion about this under the Federal CARES Act. It's a very similar provision. And the CARES Act was enacted a couple of weeks, or the first legislation that dealt with this was enacted by Congress a couple of weeks after the commissioner issued his order. We have told the insurers that they have to suspend prior authorization requirements for both COVID-19 testing and treatment. And we have reminded insurers of their duty to comply with our current network access rule in terms of use and coverage of out-of-network providers. And finally, we issued an order very recently, I think it was last week, to ensure that consumers were not balance billed for COVID-19 testing. Next slide. And that will do it for me. And I think I will hand it back over to Sue to talk about the Healthcare Authority's efforts. Thanks much.
Great, thank you so much, Jane, and thanks to all the other presenters on these very important updates. I do want to just comment that Department of Health, Department of Social and Health Services, Department of Children, Youth and Families, everybody, every governmental entity in the state has really been lead in so many of the services that and responses that are articulated and working together in the health and human services sector. But I'd like to now share a few highlights on some of HCA's response activities. Next slide. So being the first hit by the pandemic, our state really was first in the nation to lead the response. We worked tirelessly with federal partners and sought regulatory flexibilities under multiple emergency waivers and state plan amendments, or SPAs, for the Medicaid program. The state passed emergency funding relief and dispersed emergency aid to financially stressed providers. In addition, we rapidly deployed telemedicine tools and supports to providers. We worked to coordinate market strategies that support providers. We've worked to implement a number of changes and flexibilities in the Public Employee Benefits Board, the School Employees Benefits Board, employee coverage. And last but not least, we've really worked to deploy flexibilities to support the workforce. On this next slide, you'll see the emergency waivers and SPAs. And this is a long list of work, and it's by no means comprehensive, but I think it's important to highlight a couple of the components for each waiver. The Centers for Medicare and Medicaid Services, or CMS, has issued blanket waivers that apply to all states. Some of these waivers include flexibility around a provider's ability to deliver care and bill for services, expanded telemedicine provisions allowing for better access to deliver care in the home, and reduced administrative burden for our providers. Once the pandemic was declared an emergency, states could apply for an emergency relief under a Section 1135 waiver. Washington State was among the first to file for an 1135 emergency response waiver. And we have approved flexibilities for providers to deliver services in new care settings. We've made provider enrollment more flexible. We've worked to reduce the administrative barriers to care. Under our Section 1115 waiver, which is our Medicaid transformation waiver, we approved flexibilities for providers to target services based on the geographic need. We also increased rates and flexibilities for long-term care services and home and community-based services. And for our home and community-based services, allowed through a Section 1915C waiver, we've approved emergency relief under Appendix K provisions. One key highlight is that we've provided flexibilities for the delivery of care through telemedicine and alternative care settings. Last, we've been working to implement emergency SPAs, and some of these emergency SPAs implement approved waiver flexibilities, while other SPAs seek to expand response efforts and support providers. With the approval of these flexibilities, we're working diligently to implement each in a timely fashion. We're updating our billing systems and issuing new codes We're updating regulations and guides, and we're providing technical assistance supports, and much, much more. This is an ongoing dialogue and negotiations with our federal partners. So go to the next slide. One of the things we've done to support providers who were directly impacted was that we worked with our managed care organizations to support behavioral health providers with advanced payment options, providing some form of steady state funding to account for the decrease in utilization. Many behavioral health providers have been struggling financially amidst COVID-19, while some have had to shut their doors. This effort has helped to stabilize the negative trend. We rapidly dispersed $2 million to a set of 12 rural hospitals, most in need. And last but not least, we're continuing to work on financial support for hospitals, dentists, and primary care providers, including our tribal providers. This partnership has included OFM and CMS and has really focused on sustainability strategies and advanced payment solutions. Even with all of this work, there's still so much more we need to do to ensure we're not losing providers or access. As a specific example, many of our primary care providers are still struggling and may close in the coming months. Primary care is the front door to our healthcare system, and it's clear we have to take many more measures to improve and stabilize our primary care providers. Over the past year, we've been working to advance a primary care strategy that would level out the variability of primary care across Washington and put us on a path to improve outcomes that would align payer and provider incentives, and most importantly, build towards a culture of health and prevention. Now, more than ever, we need to be looking forward and work to continue these efforts. We're going to continue to advocate for support for Washington's providers, and we'll be applying the lessons learned through COVID so we can protect improvements to telemedicine and other key provisions. Another really important feature has been engagement and outreach. In February, HCA began partnering with the Joint Information Center. This was up at Camp Murray, and along with the Department of Health and the Office of the Governor, in partnership, HCA helped develop materials and content for Washington State's coronavirus.wa.gov website. This website was created as part of Governor Inslee's mission to keep informing people about COVID-19 here in Washington. HCA also played an instrumental role in launching the Spread the Facts campaign, and we continue to develop content and material for this campaign. Spread the Facts offers numerous outreach materials in multiple languages that help people communicate about COVID-19. Some of the materials include a partner toolkit, which has a variety of tools that help partners and others explain COVID-19 and reduce the stigma around this virus. Spread the Facts also includes information about scams, such as the unemployment benefits scam that has impacted many Washingtonians, as well as stimulus payment scams. Currently, we're working on messaging around mental health amidst COVID-19. As a result of these outreach efforts, along with clear communication from Governor Inslee and others, citizens are engaged. All people of Washington are engaged and empowered in building a culture of health. People are changing their habits. Staying at home has been unbelievably effective, not only with COVID-19, but with the flu and other transmittable diseases. We will continue our outreach efforts so people can continue to have accurate information to make healthy choices and build healthier habits. One of the areas that I'd like to speak to next is about bolstering mental health supports. We really like to focus on telehealth and the role it's played over the last several months to support behavioral health. But before we do, it's important to remember how much HCA has accomplished. Over the last number of years, we've worked hard to build a solid foundation, which has helped us in responding to COVID-19 effectively. Some of the foundational work includes the integration of physical and behavioral health under Medicaid. This effort helped us in responding to COVID-19. It has allowed us to coordinate across the system and connect people overnight to telemedicine supports. Our accountable communities of health are another group I'd like to call out and recognize. ACHs have been on the front line helping providers and communities and local health jurisdictions connect to resources. Our move to value-based purchasing was another significant, historic, and helpful move. The move we made, shifting from fee-for-service to supporting population health models of care, making this shift much better. Contracting based on value gave us the flexibility to be nimble when deploying telemedicine or staffing models differently. And it sets us up with data and analytics to conduct immediate outreach to at-risk populations. With this base building in Washington, we've got a leg up in a coordinated response. For all of us, mental health during this time is critical. And to support people in need, we expanded on our foundational work to provide end-to-end support to maintain access to healthcare services. We partnered with the private sector to deliver cell phones to some of our Medicaid clients, including tribal members, so that they can connect with their providers. We purchased HIPAA encrypted Zoom licenses to distribute to behavioral health providers to ensure they can transition to telehealth visits and continue to deliver care. We've also provided some laptops to providers in need. And we made sure providers get paid to deliver this care. We've enacted new billing codes so they can bill for these services. Our MCOs have been leaders in this effort, and we've been working with them to continue behavioral health integration and expand their support of the direct care providers. Last, we have recently been awarded several grants that will help us to address public education needs around these critical issues. Much more to come as we keep expanding the mental health supports that our state will need. Now I'd like to talk about how stabilizing the healthcare system has been happening. Looking forward, the healthcare system is really still struggling and still needs major attention. It's going to continue to struggle along with the broader economy. We're committed to reopening, and we are continuing to monitor the status of financially stressed providers and are coordinating across all state agencies. We're also keeping the lines of communication open with our federal partners as new issues arise. Just this morning, we've received information that $25 billion will be coming down to primary care providers from HHS. We are in negotiations about our role in getting those funds out. We want to make sure that the system is stable now and in the future. We'll be evaluating what has worked and what needs to be maintained over the coming months. If necessary, and if we are able, we will work to provide additional aid and support. So where do we go from here? What are the opportunities for Washington? As we think about the future, it will be really important to recognize the work that we still have to do, but how far we have come on this journey. Cascade Care is an excellent example. The procurement for the public option, or Cascade Care, is still underway, and we remain committed to exploring opportunities to boost access to affordable health care. We are so pleased with the responses that we received about Cascade Care. The COVID-19 pandemic has shocked the healthcare system. However, out of this disruption, there's enormous opportunity. There's an opportunity to shape the system in a way that truly supports whole person care with an emphasis on equity. We can't do this work in isolation. We will continue to partner and build on good work occurring across the state, like the governor's work on poverty and the Department of Health's work to stitch us all together to improve population health. In the coming months, HCA will continue to evaluate the impacts on COVID-19 on our purchasing strategies for all our programs. Tightening of the budgets in the coming year, although unfortunate, may also provide opportunities for us to be more creative and think across silos and really build towards greater efficiencies. We're all going to need to work together to maintain access to the critical health and social services that ensure the health and well-being of our population. Now I'm going to turn it over to Liz so she can talk to us about next steps.
Thank you, Sue, and thanks to all the presenters today. A new normal, as we've heard, a new normal is emerging due to the COVID-19 pandemic, and that will persist for many months, potentially longer. The pandemic and the more recent events that have demonstrated the racial inequities in our community have brought to the forefront some of the important topics that our work group had already begun to identify as criteria in how we assess various models to achieve universal coverage. And at the same time, our economy is being challenged, and budgets, both for individuals and families across the state and our state budget, are going to be tight for some time. As we've seen in this presentation, Washington State has moved rapidly to meet the needs of our population and expand opportunities for coverage. But as Sue said, we have more to do. That is the challenge of this work group. In addition to addressing the basic challenges of affordability, the universal healthcare model developed by this work group will be a framework around many delivery system changes that have begun to emerge and will continue, and we hope to present the opportunity to continue this type of work, such as telehealth, supporting the capacity for enhanced data and analytics to improve population health, and our focus on social determinants of health and inequities in our healthcare system and improving health outcomes. As we've learned from this briefing, HCA and its sister agencies are committed to innovation that improves the health of Washingtonians, improves the quality of healthcare, and reduces costs and improves overall outcomes. Their efforts to meet the demand over the last 3 months demonstrate this. We anticipate that in our work group, we'll continue to hear more over the next few months from these agencies about what is happening and how they're responding and how that aligns with the work that our work group is doing, and how what we put forward together can provide a framework to continue that work. So with that, I'm going to turn it back over to Sue to close us out.
Thank you so much for joining us today. If you've got questions or would like to share your thoughts about this presentation, please email us at HCA Universal Healthcare Workgroup at hca.wa.gov. We'll be posting this video to our Universal Healthcare Workgroup page along with a slide deck from today's presentation. The slide deck will also contain an appendix which has some additional information we hope you will find valuable. We look forward to seeing you at the next Universal Healthcare Workgroup on Wednesday, June 24th. Thanks so much to you all. Be safe, be healthy, and wash your hands.